Good morning, everyone.
Good morning.
Good morning.
Mark. People sliding in right now. As you come in, I ask that you please add your name and your practice to the chat, please, for our attendance. As we've discussed a couple times now, and we'll be discussing later in this meeting, your attendance at these meetings helps your primary care practice earn its rewards under the PCP reward plan. So please be sure and add to the chat your name and your practice. Thank you. We'll get started in just a minute. Please put your phone on mute if you're not participating or asking a question. Cherie, I'm going to get started. Can I ask that you keep an eye on the waiting room and let people in?
Yes,
Please?
no problem.
All right, thank you so much. Okay, I think we'll get started. We have a lot of folks on already. People keep people keep coming in, but I'll get started and we'll start with just a review of our agenda. Good morning, everyone. Thank you again for making the time to attend the June quarterly AHP practice managers meeting. We do have a full agenda. We have cut this meeting down to an hour. And so we'll move through the agenda as efficiently as we can, but please don't hesitate to put questions in the chat or go off mute and ask your question. I think we're a small enough group that we can certainly accommodate that. So what do we have on the agenda today? Of course, always our welcome and introductions. Well, I'm Renee Sutton. I am the Director for Provider Relations for Accountable Health Partners. We have a lot of AHP staff on the call. Thank you guys for being on the call and being on camera. We have some representatives from our care management team. I see Jamie Chappell and Bob Adams from pharmacy, Elizabeth Sharp from optimization, who's here to bail me out when I talk about the provider engagement report. Let's see who else. Mark Cronin, I can't forget him. He's my boss. You'll probably hear about that. Let's see, and Christy Howd from IT, AHP IT is on. So as folks pop in, please just continue to put your name and your, well, why do I forget my boss? You're just so low maintenance, Mark. You make it easy for me. So welcome everyone again. Thanks for the time. Oh, Katie Whiteman, our new care manager, program director for lactation. I probably got those words out of order, but you get the gist. So thanks for coming to the meeting, Katie. We appreciate it. So we want to talk about, most of our welcome and introductions. We have a little quick bit on our pediatric care management and expansion to the team that we hope will result in better service to your patients. Our HPV start at 9 program, just some quick updates on that. Many of you are aware that AHP facilitated a conversation between Excellis and some of our community physicians. And we want to talk about just how that, a brief note about how that meeting went. Update on Vatica Well 365, that's that risk adjustment incentive program through Excellis and a variety of other payers that AHP is a sponsor of and does support physician participation. And I want to give you some updates there. Arcadia, of course, PCP reward plan and provider engagement report, and then some upcoming incentive payments and events. And then hopefully if there's time for any additional questions or discussion you may have. So with that, for anyone who just joined us, please make sure you add your name and your practice into the chat for the purposes of attendance. And with that, I will get started. So on to our pediatric care management expansion. We're really excited to announce that we've added some staff to our pediatric social work team. We're calling them the pediatric community outreach team. And we've expanded the team really just to meet that increased volume of requests for pediatric care management services and the increased complexity of needs. And that increased complexity, that increased volume of those more high acuity and complex patients makes it difficult for our pediatric social work care managers to help out and offer assistance on maybe some of those lower acuity, lower complex referrals related maybe to the social determinants or just folks who need connection to community resources. So for that purpose, we have added 2 new team members Brianna Seawright, and Megan Willis. Welcome to the team, Brianna and Megan. Now, our intention here is that these new team members will be working as supports for the existing pediatric social work care team. So they will be reaching out, those care managers will be working with Brianna and making referral to them of your patients. We don't see any changes in workflow. Your physicians who have access to one of our pediatric social work care managers should make referrals just as they always have to their care manager. And the care manager will be doing that decision, that filtering of what will the care manager be handling personally, and what are the lower acuity needs that a member of the pediatric community outreach team could handle. So no changes to the practice workflows, no changes to how you communicate with our pediatric social work team. We just wanted to make you aware of these additional resources that the pediatric social work care managers have in order to deliver higher level service to you and to your more acute patients. I'll pause there and grab my coffee because I'm going to need to be sipping on that because I'll be the only one talking today. I forgot to mention when I started that Jana is on a well-deserved time out of the office and won't be with us today. So just like at the last meeting, I was on vacation and she handled the whole agenda. I'll be handling all of this agenda. So if there's no questions and I don't see anything in the chat, we're going to move on to our next topic, make you aware of the HPV vaccination roundtable and American Cancer Society program Start at 9 campaign. So as you know that adolescent immunization is one of AHP's quality measures. HPV vaccination is part of that adolescent immunization combo, and we're very supportive of all efforts to optimize the vaccination rates. This very important cancer prevention strategy. So in response to this growing body of evidence that shows that HPV vaccination can start at age 9 and that it does increase the on-time vaccination, increases the efficacy of the therapy. This campaign was started to support physicians, provide them access to the evidence, and support their efforts to deliver this vaccination earlier. We are a campaign endorsee of this, so we are very supportive of this move, and we are updating the toolkit that we have online to reflect this earlier start to this vaccination series. And that's that same day, same way toolkit. And we're updating that to reflect this new start age of 9. We're also going to be referencing it in our summer issue of Quality Corner. That's our reboot of AHP 5. That's the clinical newsletter that AHP puts out. So a lot more to come about HPV Start at 9 in the Quality Corner. I should also mention that AHP is being supportive and helpful to an effort by Dr. Cindy Rand, who's a Golisano pediatrician, who is conducting a study to determine if implementing standing orders for HPV vaccination would improve the rates of vaccination for HPV. And Dr. Rand may be reaching out to some pediatric practices to interview them, to ask them about their processes relative to HPV vaccination, and just trying to understand how implementation of standing orders might benefit your HPV vaccination rates. So we want to make you aware that that outreach is happening, and Dr. Cindy Rand is the lead investigator on that. It's totally on the up and up, and we hope if your practice operations allow for your participation that you would be supportive of this study. Any questions on HPV Start at 9? More to come in the summer issue Quality Corner, of course. No? Okay, we're just flying through the agenda today. I'll slow down and try to take more sips of coffee and remind everyone again, please put your name and practice in the chat. So the Excellus reimbursement discussion, which really is a misnomer, we actually kind of branded this meeting as being about private primary care sustainability. How do we keep our private primary care healthy, financially viable, and they're serving a tremendous volume of patients that you serve? And how can Excellus partner with us to ensure that private primary care continues to be viable? We had a number of practices represented. We had Legacy, Elmwood, Irondequoit, Long Pond, and English Road Pediatrics. And from the adult side, we had Internal Medicine of Brighton participate. We reviewed with the folks from Excelis, and this included one of their contracting executives, as well as the value-based purchasing team that works closely with AHPs, like our value-based account managers. Together, we reviewed how, the flattening of the rates, higher expenses that your practices are experiencing, the growth of Medicaid and the payer mix, how that just continues to expand, and then that prevalence of behavioral health conditions and high acuity visits taking up a lot of provider time, how all of those things together are leading to a crisis. And we kind of styled it and appropriately so, I believe, as a tsunami, right? A perfect storm of growing disparities in care and unsustainable primary care practice. We made the case that fee-for-service rates for any line of business are insufficient to sustain private primary care. We talked about the growth of Medicaid. We talked about current value-based incentives, which, AHP is really the agent of passing those along to you. And, have to own that the volume of those, the size of those don't close the gap to make up for the flat rates and the higher acuity visits and the longer time that they're taking. And we also made the case that we can all agree as members of this community that anything that threatens private primary care, that possibly would cause them to close their doors to all of these Medicaid patients that they're taking right now, will only contribute to further disparities in Rochester, disparities in access and outcomes. Rochester is a great place to live. I'm hometown Rochester, born and bred person. I love this city, but we have to acknowledge that it has its problems, and it was really shocking to me to see some of these stats of Rochester being the third ranking city in the U.S. for overall poverty, and the second for childhood poverty. I also found it interesting that ACT Rochester is a local organization that does a lot of work in the healthcare space and in issues of access and equity. And they did a study to put our poverty rate in even further context. They compared us, they put us in a bucket with 17 other cities that are more similar to Rochester, right? So an apples to apples comparison, and like a benchmark group that include like Buffalo, Hartford, Connecticut, Tulsa, Louisville. And among this benchmark group, Rochester ranks first in overall poverty, childhood poverty, and extreme poverty. And the healthcare space has a lot of potential to help address that. And we need Excelis to be a partner to help us address that. And these were just some of the asks. We're asking them to help with fee-for-service rates. We're asking for more robust benefits for the Medicaid beneficiaries that specifically target social drivers of health. And we're asking for their support and better communication with all of you to help you ensure that when there are changes that you're aware of them and you can bill appropriately to account for them. And one example we gave was that preventive services coverage grid, which includes all of these codes that supposedly pay, but that most recently stopped paying for Medicaid products. So these were some of our asks. It was a productive meeting. I felt like the Excelis folks were receptive to this message, and we're going to have, and that was the start of a conversation. So my update here is not that we solved any problems or to announce any massive rate increases, but rather to let you know that Excelis was receptive to the message that our private primary care need a partner who's willing to invest in them and invest in this community in order to sustain private primary care, because it is in everyone's best interest. So they did agree to a future meeting. We're looking at the end of July and the early August timeframe. So a million thanks to the practices whose providers participated. A million thanks to those practices and their practice managers who gave us the data that we needed to make our case during this meeting. You were so helpful and responsive. And we will continue to be working with the same group as we schedule a future meeting, which we're looking at for around the end of July, early August timeframe. I'm going to take another breath. Is anyone?
Yeah. And Renee, as you take another breath and sip of coffee, I'll just chime in. I think Renee has summarized the meeting very well. I think it was productive. I think the Excelis folks were listening and had a lot of questions. I think for us, our purpose, we certainly want to advocate, and I don't have to preach to this choir about the incredible importance of private practice primary care in this community and the challenges that it faces. And I think all the physicians who participated and Renee and members of the staff who prepared for it prepared well with real data of, it's one thing to say, well, gee, rates haven't gone up, but when you actually quantify what it's looked like over the last several years, it tells a compelling tale. I want to be clear, we are not negotiating fee-for-service rates on behalf of the private practice physicians. That's not our intent. But we wanted to give visibility to the issue and point out that, this isn't just people whining. This is a serious problem that needs to be addressed. That the solutions aren't simple or easy or overnight. And I think Excel says a lot of internal contemplation and consideration, which is fair for them to do. And as Renee says, we'll be talking to them again. And I hope as they look toward 2024 and they're planning and looking at what they're going to do with fees and policies and whatever, that we have importantly informed their contemplation.
Thank you, Mark. Okay, any comments or questions? Otherwise, I will be moving on. Okay. Vatica Well 365 program. So we've definitely talked about Vatica before with this group. So Vatica is a vendor who's working with Excelis and a variety of other payers. They provide an online system to help providers do what's called essentially a coding exercise. And this covers patients for all lines of business now, although AHP's interest in the program is really in the Medicare Advantage space, to ensure that these patients are accurately coded and their acuity is captured. And in turn, our providers who complete these coding exercises earn pretty great incentives. So you're not only being reimbursed for the cost of the visit, but then also earning an incentive for completing the Vatica encounter. So our form of supporting Vatica and helping our providers contract with Vatica and get started on doing these coding encounters or coding exercises, I guess. We're also providing for it in our PCP reward plan, which most of our meetings actually dedicated to. So I'll talk a little bit more about how working on Vatica helps your providers earn rewards under AHP's PCP reward plan, in addition to the incentives that you're earning through Vatica. So it's available on commercial Medicare and Medicaid. It can be done for any substantive visit, so physicals, annuals, even sick visits. And you earn an incentive, which is $175 for every coding exercise that's performed. And then at the end of the performance year, if the provider has completed more than 65% of their eligible coding exercises, an additional $50 is tacked on to every one of those that they did complete. So these are pretty good incentives. We have providers who are very enthusiastic about the program and are really able to move through the system very quickly. Everything is integrated into the Vatica system, so providers don't have to switch back and forth between your practice EMR and the Vatica online tool. Everything's been imported into the online tool, and the provider is able to see the full record of relevant information for that patient in order to complete the coding exercise. For 2022, we had a slight erosion in our rates overall. So all lines of business, we had about a 37% completion rate in 2022 compared to 38%. We do a lot better when we look at line of business. The Medicare Advantage business is completion rate is better than the overall visit. And this has resulted in about $4 million paid to providers and health systems just in base incentives for 2022. And as I referenced, while AHP has been involved in it really in support of AHP's Excelis Medicare Advantage deal contract, value-based contract, there are other participating payers. So I should remind myself really that when I say $175 per visit and then the $50 bonus should you hit that 65% completion rate, really applies to Excelis. AHP doesn't have visibility into what exactly the incentives are paid by MVP, Humana, WellCare, HealthNow, Univera, Fidelis, and Independent Health, but all of those payers are participating as well. So if you haven't heard about Vatica and you're interested in learning more, Jana is AHP's Vatica point person, and you can reach out to Jana to schedule a demo for Vatica. And if you have any questions about your practice's current participation in Vatica. Any questions? Okay. Oh, Tanya, thank you for your comment in the chat regarding our last topic about our Excelis meeting. We're always going to advocate for you. You're our partners and you're the key to AHP success. So we want all of our provider practices, our private practices in particular, have so much to struggle with to be successful. And we're happy to support you in that. Okay, I'm going to move on to the Arcadia update. So Arcadia, that is our data aggregation system that, due to our relationship with Excelis and our value-based contracts with Excelis, that we work with and have implemented in the EMRs of our practices, our primary care practices that participate on our contracts. So every year, Vatica needs to be updated. I'm sorry, Arcadia needs to be updated with the new measures, the new thresholds for those measures, in order for you to have visibility into your performance. So the 2023 measures are live now in the Arcadia dashboard, and we ask that you please log in, check out your performance, and if you have any cause for concern that what you're seeing reflected on the dashboard relative to your performance doesn't really true up to what you're seeing in your EMR, you're urged to please reach out as soon as possible to Willie Newdigate for assistance. Our folks are also reminded, because we understand you don't have a lot of cause to log in to Arcadia until measures are updated. And last year with our data issues, many folks may not have logged in at all. So if you haven't logged in since August of last year, you're going to have to do a password reset. So I just want to remind you of that. And any problems that you may have with that, you can contact Willie for assistance with that. So Arcadia is up and running. Please log in and see how you're doing. If you have new providers or new office staff as well who need access to Arcadia, you can reach out to Willie to arrange for access and for training. Okay. Any questions on that? Okay, well, I'm going to move in then to the PCP reward plan and the provider engagement report. You guys might be rolling your eyes like, gosh, Renee, this has been on the agenda of every practice manager's meeting. It feels like since the beginning of time. I appreciate that perspective. But one thing that has been missing from our conversations about the PCP reward plan for 2023 or 22 was how exactly, what are the specific behaviors that earn the incentive, right? We've talked about, well, you get 15% for pharmacy and 15% for LARC, but what's the thing in LARC that gets you that 15%? What's the thing in pharmacy that gets it for you? So we want to go over that in detail today, particularly because for 2023, we have reinstated the PCP reward plan with like full accountability. We talked about it in prior meetings that for 2022, we're holding providers harmless. We had issues with Arcadia. It wasn't a reliable tool for you to use to manage your performance. We had issues with implementation of the provider engagement report, some of which was related to the Arcadia issues that gave you no visibility or opportunity to work on the things outside of the quality measures, right? Those other components of the reward plan. So you were held harmless and for 2022, and we'll talk a little bit more about the 22 payment later in our agenda. But do want to say we're going through this detail for the 2023 reward plan because we're in it now and accountabilities have been reinstated. And Arcadia is ready to go, the PER is ready to go, and we want to make sure that everyone knows exactly what it is that optimizes your incentives. So just a reminder that the PCP reward plan combines the quality incentive payment with what we called gain sharing in prior years to now just one PCP reward plan payment. And the purpose of implementing this specific reward plan was it better aligned your incentives, your providers' incentives, with our network's accountabilities, specifically cost performance. We talked about this before when we talk about value-based contracts. It's not enough to just do well on quality. You got to save money in order to have something to have a gain to share. So that was why the PCP reward plan added those accountabilities relative to cost performance for providers. And it's paid out in September of the year following the performance year. So in September of this year, we'll be paying for 22, the year you were held harmless. And in 2024, we will be paying out your performance for 2023, the year we're in now. So let's get into it. So PCP reward plan has 5 possible components listed along the left side of that screen. We've got the quality measures, depression screening, citizenship, pharmacy cost savings, and LARC. And you'll notice I have it in specialty up there that, family medicine, and that should say family medicine or med peds. We believe that those are the specialties that are likely to have opportunities in all 5 components, which then adds up to 100%. Now, internal medicine, we're saying, well, that's not likely to have the volume of patients who, LARC would be of interest to, that specific specialty. So LARC wouldn't be a component that most internal medicine providers would have opportunity in. So we've shifted the 15% for LARC up into quality measures. So for a provider who doesn't have opportunity in LARC, that 15% pops up into quality measures. Same is true like for pediatrics. The pharmacy cost savings program involves adult drugs. It's not likely pediatrics will have opportunities in pharmacy. So their 15% pharmacy goes into their quality measures. 60 is now, so quality measures are worth 65% because they don't have opportunity in pharmacy. And then this last column is just to reflect any. We may have we have quite a few providers in 22 that had had opportunities neither in pharmacy cost savings nor LARC. So 80% is the value for their quality measures to push that up into that value. So that's how it breaks down in percentages. And of course, the provider engagement report is where you're going to be able to manage those various components and see your performance all along the way of how you're doing. Gives you insight into how you're performing against the reward plan. Arcadia remains your destination to see how you're doing specifically for quality measures. But for those other components, citizenship, depression screening, pharmacy costs, and LARC, the PER is where you're going to go. And we'll go through each component and show you where in the PER that component is covered by it. Okay. It's also, the PER not only gives you insight into your provider's performance in these specific components, there's also data available in it that you can drill down into to identify, all right, so I'm not doing well in depression screening. Who are the patients not getting screened? And be able to see that within the PER and download that report. It's only going to display the components for which an individual provider is eligible. So if a provider doesn't have opportunity in LARC or in pharmacy, those boxes will indicate that. And it's going to display the data based on the level the award is made. So depression, for example, is rewarded on a practice level. So you're going to see the whole practice's performance on depression screening. Whereas LARC and pharmacy is on an individual basis, and you're going to see individual data. Okay, so now let's dig into it even farther. So quality measures. Yeah, okay, knew I had an animation in there. So for quality measures, which is worth the biggest chunk of the PCP reward plan, 50% of it is going to be worth it. And how do you earn it? How do you earn the full 50% or 65%, whatever your individual provider's percentage might be? Well, it's based on your percent capture of points. The purpose of this chart is just to show this is the whole provider-facing grid and the points associated with them. And you'll notice I have it separated by the family medicine, internal medicine, and pediatrics. So family medicine is eligible really for 100 points. Internal medicine is only eligible for 60. Pediatrics is only eligible for 40 points. The points in their space all total up to 40. To earn the maximum quality and component in the PCP reward plan, a provider has to earn, so to earn 100% of the reward, they have to earn 75% or more of the points they're eligible for. And that's a moving target, right? Depending on how many points your provider is eligible for. So for family medicine, that means earning 75 or more points. For internal medicine, it means earning 45 or more points. And for pediatrics, it means earning 30 or more points. Silver, you earn 75% of the quality component for silver performance. And that means that you've captured between 45 and 74% of your points. And then as you move through this table, it shows you what exactly 45 to 74% means in real points, depending on your eligible points. So let's walk through an example real quick, just to illustrate how this works, because I understand it's confusing. I'm saying that your quality measures is worth 50% of your total reward, but you can earn 100% of it or 75% of it. So I know it's getting confusing with all these percentages. So let's just walk through a quick example here. So let's say that of the total PCP reward plan, the quality measure component is worth $6,500. Let's say for 20, and this is just an example, for 2023, let's say that the quality measure portion is worth $6,500. So provider one is a pediatrician who's eligible for 40 points. They earned 31 points. That is within that, and that's 75% or more of the points they're eligible for. That's gold level performance. They earn the full award, $6,500. Provider two is an internal medicine provider, and her performance at 43 points out of 60 makes her eligible for silver because that performance is within that range. And that is worth 75% of the quality component. 75% of 6,500 is 4,875, and so on. And then provider three is family medicine, and you'll see they earn 43 out of 100 points. That qualifies them for only 25% of the 6,500. What is 1625? Okay. Any questions? That's just the quality measure component. The resources available for you to this are all on ahpnetwork.com. That's where you're going to find the full provider grid of the quality measures. You're going to see those individual pages for every measure that outlines how to what qualifies a patient for the denominator and what qualifies the patient for the numerator, right? What are the behaviors and actions that close the gap? Have there been any changes in the measure since the prior year? What exclusions apply to the measure? And then also very helpful, shows you up above, it also shows you on that sheet how the thresholds may have changed. Did it get harder to earn the 90th percentile in that measure, or did it get easier? That's all going to be shown to you on those individual detail sheets on ahpnetwork.com under the quality measure section. And that stuff is all available and live today. And Arcadia, of course, is going to be your best source of information about how you're doing in a given moment for your quality measures. So again, can't say it enough. Please, please, please log into Arcadia, look at your measures, look for any issues you see and report them. We want to have not only enough time to identify issues. If there's a data problem that requires an Arcadia fix, we need time to get it fixed. If there's a problem that will require a change in workflow, we want to have time to work with you on that in order to still optimize your performance before the end of the year. So with it being June, really can't state it enough to please log into Arcadia and see how you're doing. Okay. Next section of the PCP reward plan is depression screening. And I invite Elizabeth to back me up in any way that she sees fit as I go over this information, as Elizabeth Sharp is our depression screening guru at AHP. So this is a measure that will apply, or a component of the reward plan that every provider, every PCP on our value-based contract will be participating in. Okay, so that's really those top three measures. Everyone has opportunities in quality measures, depression screening, and citizenship. That will apply to everyone. So how do you earn the 10% award in depression screening? You have two ways. You can achieve a 70, and this is at a practice level. Your practice as a whole achieves a 75% or greater rate of depression screening for patients ages 12 and up. But if your practice, let's say, isn't at that rate, you haven't achieved a 75% rate, you're not there yet, but you have achieved an increase over your own performance from the prior year. So you have two ways at it. You can either achieve that 75% or greater, or you can demonstrate performance over your own prior year baseline. Those are the two ways that you satisfy the depression screening PCP reward plan component. That third bullet there is another aspect of depression screening, the follow-up piece, right? Appropriate follow-up within 30 days of the positive screen, but it is not a component of earning it for the PCP reward plan. It's just those two things. And on the PER, you're going to be able to log in, see actionable data for that year. You're going to be able to view and export the patient lists of folks who have not received depression screening and be able to drill down right into the individual provider. Although, again, it will be awarded on a practice level in recognition that this is very much a practice function to do these depression screenings. There are a variety of resources available on ahpnetwork.com to support your efforts in behavioral health in general, but depression screening in particular. If you go into the clinical area and the toolkits, you'll see a lot of resources available for depression screening. very important aspect of the PCP reward plan and of our work in 23. I'll stop there for questions, or if Elizabeth would care to weigh in and do a better job than I just did talking about it, please feel free.
I'm always happy to weigh in, but I don't think I could do a better job. That was wonderful, Renee. Very comprehensive, so thank you. And for the folks on the phone, if you have any questions at all about the provider engagement report, particularly for depression or about the depression screening initiative, please don't hesitate to reach out. Happy to talk offline, dig into your data, whatever's helpful.
Okay, thank you, Elizabeth. Okay, so moving on. What is the next section? Oh, my little animation didn't work, but we're going to talk about depression. There it is. We're going to talk about citizenship next. Citizenship. So that's one that also applies to every provider in the PCP reward plan. So how does the provider earn that full 10% of the PCP reward plan for citizenship? This is another one that has two passes at it. We want to make it easy for providers to earn this, but we also want to, encourage those behaviors that reflect that you're well engaged in AHP and that you're getting the information you need, and that you're doing the work that we need to do together in order to maximize our performance as a network. So the first slice of satisfying the citizenship component is on the practice level. And if you complete 2 or more practice level components, then every provider in the practice gets that full 10%. And that's an all or nothing measure. You earn it or you don't. It's not like quality measures where you can earn 100% of it or 75 or 25. It's 10% or it's 0. So there are activities that satisfy this at the practice level. And those activities are things like your practice manager attends 2 or more practice manager meetings in 2023, or your practice is piloting or participating in an optimization or an administrative project. Maybe you're meeting with our pharmacy team, or you've implemented by the PER. If you've checked 2 of these boxes, every provider in the practice is earning their full 10% on the citizenship award. But sometimes that's not possible. And we want to give a chance for individual providers to earn it on their own if their practice isn't doing these things that gives them the award automatically for the whole practice. So those individual components are things like the providers attended clinical grand rounds. They're agreeing to receive our email communications. So every time, very often we send out an email communication. Constant Contact is a vendor that we use, and providers may unsubscribe. That would, mean that they did not satisfy that particular component of earning an individual citizenship award. If providers are accepting new patients at the time of the incentive calculation, that would also stand as an individual check for earning citizenship. Serving on one of our advisory committees, the Adult or Pediatric Advisory Committee, serving on the AHP board or board committee, or completing 20% of targeted Vatica visits for the Medicare line of business. Not a real high bar, but we want to start low because it's our first time including Vatica as any kind of element of our PCP reward plan. And you can expect over time that we're going to increase that threshold. But those are the components of citizenship. Any questions about citizenship, please feel free to reach out to myself or to Jana. And again, on the PER, you're going to see right in there whether or not your provider has satisfied the components for citizenship. Or I should say you will see. That one is not quite live yet, but it will be. And if you have any questions or any concerns that between your practice activities or the individual activities in your practice, any concerns that citizenship isn't being satisfied, please feel free to reach out to me and we can take a look at that even before the PERS. That component's ready to roll. Okay. Any questions? Okay. And I shouldn't just pick on Elizabeth. I'm sorry. Any member of the AHP team is welcome, obviously, to weigh in. I mean, you saw Mark do it. He just dove right in. So anyone can do it. All right. I'm going to move on then and start talking about those differential ones. These are really complicated. Well, the pharmacy one in particular has a lot of moving parts. And pharmacy is worth 15%. And this is a cost savings one. This is one that is part of that effort to align what we're asking our providers to do with what the value-based payers are asking us to do in our value-based contracts. So the pharmacy cost savings is worth 15%. And Bob Adams is on the call and he can weigh in as well if I'm getting any of this wrong. So how do you earn that full 15% of your pharmacy cost savings PCP reward plan component? Well, also 2 ways to do it. And this is a slightly differential one. where it isn't all or nothing. You can earn 100% of the reward, or you can earn 50% of the reward. And it's all driven by provider prescribing in these 4 classes: insulin lispro, long-acting insulin, metformin, and NSAIDs. So what exactly does that mean? So let's walk through an example of how this works, because there are, as I said, 2 ways to earn it. Either your providers are prescribing these drugs at rates, and we want to encourage switches to lower cost drugs here. So they're switching their patients to lower cost drugs, and they're doing it at a rate that's at or above the rate that the network's doing it. If they're doing that, they're earning 100%. If they're not doing that, they're not doing better than the network, but similar to depression, right? They're doing better than their own performance in the prior year, then they're going to earn 50% of the award. So let's walk through an example, because I appreciate that could be a little complicated. So let's say that the pharmacy component is worth at max $1,500 under the 23 PCP reward plan. Again, just an example. So first of all, we're going to look down and see, does this provider have opportunities in every class? This provider doesn't. They don't have any opportunities in NSAIDs. So the 1,500 is divided by 3, and the max award in each component is $500 because there's no opportunity in this one. So let's look line by line. Insulin Lispro. Did the provider do better than the network? Yes. Did they do better than the prior year? Doesn't matter. They did better than the network. They earned the full $500. Long-acting insulin. Yes, that's an opportunity. Better than the network? No. Better than the prior year? Yes, they did. They didn't beat the network's performance, but they achieved better performance than they did the prior year. So they earned 50% of the award in that component. So $250. Metformin. Patients in the class? Yes, it's part of their opportunity. Did they do better than the network? No. Did they do better than their own performance? No. So they earned 0 for that component. So their total award is $750. Okay. And then this example, and I won't spend too much time here, is just to show that if you have patients in all 4 classes, then the max award, the 1,500 is divided by 4. So the performance in each class is worth then $375. Okay. So it's a little, there's a lot of moving parts to the pharmacy award, but, it strikes a great balance of giving providers lots of opportunities and across 4 different drug classes. Ensures that if they don't have an opportunity in a given drug class, that the dollars are moved up and shared among those in which there are opportunities. And then 2 slices at it. Did you do better than the network? And if not, did you at least do better than you did yourself in the year prior? And lots of resources available for this one, the PER in particular. So I've got highlighted here the section of the PER that demonstrates that for this particular driver or particular doctor, physician, they're doing well. They're at or above the prior year's network baseline in metformin and NSAIDs, but not doing as well against the network performance in insulin lispro and long-acting insulin. And then if they were to dig into that section on the PER, they would get more detail about their specific performance, be able to drill down into their current status, identify patient opportunities. And then there's also a medication-specific initiative drill down where you can actually find the list of patients who haven't been switched to that lower cost drug, download it, hand it over, and have those patients switched if indicated. I will say that this is an important one for your providers to pay attention to, for you to get in front of your providers, because there is an opportunity for a little back and forth with our pharmacy team here. You may have patients on this list who are shown as being an opportunity to switch to a lower cost drug, but that your clinician knows, no, it's really not an opportunity for this clinical reason or that clinical reason. And they can consult with our pharmacy team and have that patient removed from the denominator in order to reflect the provider's better performance in that. So this is an important one for your providers to take a look at, identify patients whom they don't agree are really opportunities for a switch to a lower cost drug, and then have them reach out to our pharmacy department, have that patient taken out of the denominator to ensure that the performance is optimal. Okay. Any questions on that, or Bob Adams, anything you would add from our pharmacy team?
No, you rocked it. Yeah, very excellent explanation of a complex situation. So great job. And similar to what Elizabeth said, if you have any questions or you want to talk about those patients that you don't feel fit that clinical profile, please reach out to us, the pharmacy team, and we're happy to meet with you and walk through this or even just clarify it for you. So no worries there.
All right. Thank you, Bob. Okay, so that was pharmacy. And then the final component of our PCP reward plan is LARC, long-acting reversible contraception. This was an initiative identified as some area where our pediatrics or providers who care for children and young adults can participate in an initiative that does have cost savings implications. So how do you satisfy that? How do you earn the 15%? So this is another one like citizenship. That's all or nothing. You earn full 15% or you earn nothing. How do you earn it? You've got providers have quite a window. Okay. They have from between 1/1/2019 to the end of 2023. If they have attended at least one reproductive health counseling training sponsored by AHP, and I believe AHP is going to be announcing new classes for 23. So you've attended at least one reproductive health counseling training, or you've arranged on your own with the vendor to have the Nexplanon placement training. So any of those, you've done Nexplanon placement training, or you've done those one reproductive health training anytime between January 2019 and the end of 2023, your provider will earn the full 15% of the PCP reward plan. And LARC is shown right here. And what that'll look like on LARC is that, there'll be an X saying, oh, you haven't earned it. You need to attend the LARC training in order to earn this reward. Okay. So I want to really quickly, I know we're running out of time. I do want to leave time for questions, but I want to run through the whole reward plan, a couple of examples. So hopefully it all gels everything I just covered. So I want to show you an example of a pediatrician. And let's say the 2023 PCP reward plan maximum award is $10,000. And this pediatrician has opportunities in 4 areas: quality measures, depression, LARC, and citizenship. So this lays out what the percentage of the total reward is based on this provider's unique situation, because they only have opportunities in 4. So quality measures for this provider is worth 65%, depression 10, LARC 15, citizenship 10. The max award, because 65% for quality measures, $6,500 based on the max overall award of $10,000. So this provider earns 78% of their points, which qualifies them for gold, or 100% of the quality measures component, which is $6,500. They met their criteria for depression screening and earned the full award of $1,000. They met the criteria for LARC. They took that training sometime in that 4-year period and earned their full $1,500. But citizenship, unfortunately, which was worth $1,000, the criteria wasn't met, and they earned no incentive, and they left $1,000 on the table. So that would be, one example of how a provider would earn an award. This is a family medicine provider who has opportunities in all of the components of the award, showing, and because they have opportunity in all components, quality measures is worth 50% of the max award of $10,000. So it's worth $5,000 for this provider. They only earn the bronze level though, so they only earn 25% of their quality component, which is $1,250. Depression screening, they earn their full amount. LARC, they didn't satisfy the criteria. Pharmacy, this foots back to one of the examples I showed you. They earned the max award in 2 of the classes in which they had opportunities, 50% award in 1 of the classes that they had opportunities, and no award in a class that they had opportunities in. So they had opportunities in all 4 drug classes, but only earned awards in 3. So they earned $938. And then citizenship, their criteria was satisfied, and they earned $1,000. So altogether for this provider, really driven by that poor performance and quality measures, of a relatively small total reward compared to that max of $10,000. Okay. We've got 11 minutes left, and I want to leave time for questions. So I'm going to pause here. Oh, we got a question from Chris from Stony Brook Pediatrics. What if they were already trained prior to 1/1/19 and they've been placing the Nexplanons and continue to do so? Chris, that's a really good question. And I appreciate that, because that's one where you're actually doing the activity, right? It's not just about training. You are placing Nexplanon. But unfortunately, this is how we have defined the LARC piece for the PCP reward plan. It is the training. We do anticipate that in future iterations of the reward plan, actual Nexplanon placement will satisfy it if LARC remains in the reward plan, but not for 2023. So we do want to provide opportunities for your provider. If you have one who meets the description that you just gave, they're placing Nexplanon, but they haven't done the training. We want to give them an opportunity to obtain that training. And it is free. It's sponsored by AHP. And we certainly endeavor to make it as conveniently scheduled as possible. Okay.
So
Good
Renee,
question.
I have two that did the training, but I'm pretty sure, I think they might have, well, maybe they did do it in 19.
Okay.
Is that when you started offering the training for us?
Yes, that is when we started, and we've maintained those attendance records. So if you
Okay, then maybe those two are all set then. So is there a way for me to just send an email to you for you to check?
absolutely, please do.
Okay, perfect. Thank you.
You bet. Good question. Thank you for asking it. Any other questions about LARC or other elements of the PCP reward plan in general? I know there's a lot of moving parts to it, but when you consider, believe me, if you looked at the moving parts involved in one of our value-based contracts, let's say with Excelis or MVP, this reward plan has nothing on moving parts compared to those contracts. And the whole goal here is really just to align what we're incentivizing providers to do with what we are incentivized as an aggregate network to do under these value-based contracts. So we hope that, this run through is helpful, because that's kind of, it's been missing from our communications about it, is what's the thing, what's the exact behavior that earns the incentive. And I hope that you've learned that today. This session is being recorded. It'll be uploaded on YouTube. You'll be able to share it with your providers. And of course, I'll be sending the slides out as well. But interested in your feedback about the plan. Just, want to know what you think and what other questions you might have about what you've heard already today. Everyone's sick of the sound of my voice and they just want the meeting to be over. So I will move on and leave it that you are more than welcome to please, reach out with any questions you have. Just to recap here, the provider engagement report is going to be your best tool for understanding how your providers are progressing towards optimizing their incentives under the 2023 PCP reward plan. If you don't have access to the PER, please reach out and we will get you guest account access. There's a little bit of a process in order to get you the credentials that you need to be able to log in, and hope folks understand. And although the process is a little torturous, it's all in the service of ensuring good security of our data. And if you see any issues in the PER, please reach out. And also, if you see, of course, back to Arcadia, any issues with your Arcadia data, please reach out to Willie Newdigan as soon as possible so we can get working on straightening those out for you. Okay. So I'm going to just move on with our agenda and just get on to what are our upcoming incentive payments. I'd like to tell you what's coming up next. So first quarter 2023 clinical integration. So that is your payment to our PCPs based on their attribution under our MVP and Excelis contracts. And we pay that to our providers at the rate of $1 per member per month. We pay that on a quarterly basis, and we're always about a quarter behind. So first quarter 23, we anticipate getting those out sometime in July. Fingers crossed. We still we have to assume that we're going to hit that time frame, assuming we get all the information we need from the payers. So we do have a dependency there that really drives the schedule. And then 2022 gain sharing, which will be the 2022 PCP reward plan payment for PCPs, and then gain sharing payment for all other specialties and members of AHP. That'll be coming out September 2023. Don't have any real details yet. As you've certainly heard me say many times before, it's our board that determines exactly based on the gain sharing that AHP has available for distribution to the network. The board determines what percentage goes to PCPs, specialists, hospitals, and so on. The PCP reward plan for 2022, our providers have been held harmless due to the data issues that I referenced earlier in my conversation. So everyone will be, generally speaking, getting around the same amount for the 2022 PCP reward plan. But for 23, accountability is back. And just a reminder to look at the PER and Arcadia to ensure you're doing your part to optimize your providers' incentives. So that's what's coming up for payments. So July for CI and September, maybe August, if we're lucky, late August for PCP reward plan and gain sharing. And then on to some upcoming events. Tomorrow's update call. We are not having an update call tomorrow, so that is canceled. So no need to give us your lunch hour tomorrow. An email is going out shortly to let folks know that that call has been canceled. And I do try and keep up the discipline of still logging into the call and throwing up a slide that says the call's canceled in case anyone misses that message. But tomorrow's update call is canceled. Our next practice managers meeting is Wednesday, September 20th. So hard to believe it, but we're nearing the end of June. Summer's going to be over before we know it, and it will be over by the time we meet next, September 20th, when we'll have a recap of our gain sharing payment and then also a preview of the 2024 employer plans in case there's any changes to benefits or AHP's role as the tier 1 network under those employer plans. And then the last event I want to make sure that are on that's on folks' calendars is we do have a fall clinical grand round scheduled for October 25th, 5:30 to 7 p.m. We're going to hold it virtually, and we are planning as well that this will be another event where we'll be splitting after a general session, splitting it up into pediatric and adult focus groups. Okay, 4 minutes to spare. I don't know how much of an open discussion we can have in 4 minutes, but I'm game if you are. What are your pain points? What can I help you with? What questions do you have? What can we do to help? Okay, I guess if you have any thoughts on that or you want to continue that discussion offline, I'm always available. You can reach out to me via email. And obviously all of members of the team are available. Cherie Turpin, who's on our call today, is our provider data coordinator, and many of you have been working with her on those per guest accounts. Jana, my colleague in provider relations as well, is your main point of contact for Vatica. Myself, Elizabeth Sharp for optimization, Willie for Arcadia. Our BHI team and our pharmacy team are also available to you. And as always, I like to end with our reminder that, yes, please remember when folks are calling and asking, is your practice an AHP, that yes, you are an AHP participating provider. Please remember to refer to AHP specialists, hospitals, imaging, and labs. So our patients and our network as a whole can benefit from the better coordination of care, from the care management resources available to providers in AHP. For all those things, all those benefits of being a clinically integrated network are really only maintained if we do our best to keep our patients wherever possible in network. I encourage you to do so. Please let me know if you need any door clings or anything else that helps remind you and your staff that you are members of AHP. Okay, my clock shows 2 minutes to spare. We've reached the end of our agenda. I'll make a last call for any comments or questions. Jerry, thank you so much for your comment in the chat. We appreciate you so very much, all of you, for all that you do to care for patients. It's been a difficult time. Our difficulties continue post-COVID. We know the challenges that many practices are facing, and please don't hesitate to let us know how we can help support you in any way. So have a great day, guys. Have a wonderful summer, and we will see you again, at least for this meeting, in September. Take care.
Have a good day, everyone.
Thanks, Renee.
Take care, guys. Bye.